And our goal is a Kenya where a child in a remote village receives the same standard of care as a child in an urban hospital. When we look at the progress up to where we are today, Kenya's commitment to safeguarding the lives of mothers, newborns, and their children is steadfast. We have made tangible progress. One, by investing in the primary health care and rolling out our community health strategy. Secondly, strengthening the primary health care networks to bring services closer to the people and to the families. Again, you have also seen that we have deployed our community health promoters, who are our frontline workers, as the first link in the chain of care, identifying risks early, delivering life-saving interventions, and also ensuring timely referrals. Not every pregnant mother knows that they need to go for prenatal care. In fact, they think, hii sio ugonjwa, and they say it often. So with our community health promoters, we have been able to reach out to more than 350 pregnant women who have been identified, and 136,000 of them have been referred to the nearest facility just for checkup. And again, they have also been able to reach to about 10 million children below the ages of 5 years. This is basically to assess common childhood ailment and at the same time issues to do with malnutrition. And when they find that there's a problem, they refer them to the nearest facility for further assessment. This symposium reminds us that safety must be designed, implemented, and sustained from the very start at the point of birth, linking patient safety with community health and primary care. And to protect these children, the newborns especially, let us strengthen the foundation at the community level. You know, Aga Khan is a community by itself. Where your facility is, this is a community. You don't expect to find any other community in Nyeri or Eldoret or wherever else. This is the community that you must be able to reach out to with health promotion, preventive care, and timely detection of complications that prevent tragedies before they unfold. Learning, we must learn from safety incidents, not just to assign blame, but to improve. Many a times is when an accident happens, maybe in Aga Khan, and we will go back and forth. I don't know, KMPDC, it's the regulator that allowed so-and-so to operate. Yeah, the hospital is saying it was not us. And we keep pushing and shifting blame from each other. We must improve from those problems that we have had in the past. And every adverse event and near miss is an opportunity to strengthen systems and prevent recurrence. And this happens with transparent reporting, supportive leadership, and the courage to change practices that put patients at risk.
Kenya has been a front runner in advancing universal health coverage. I'm sure you can attest to that, and you've seen it, by the way. And also quality of care. Madam PS and the government of Kenya, your commitment to save more equitable health services inspires not only this nation of Kenya, but also many other countries in this region. And in UNICEF's Eastern and Southern Africa, newborns account for more than 40% of under 5 deaths, showing that the first days of life remains the most dangerous. These numbers are not abstract. They are mothers losing babies within hours of delivery, and families devastated by tragedies that should have never happened. Yet, 2/3 of newborn deaths in our region, in Eastern and Southern Africa, which has got 21 countries, could be prevented with simple, cost-effective interventions that has already been presented by the previous presenters. Of course, at UNICEF, we are very much proud to stand with the government of Kenya and other governments in the region as well, hospitals like Aga Khan and communities to change this reality. Let us leave this symposium with a shared resolve that across Kenya and Eastern and Southern Africa, and also in our African continent, no child should be harmed while seeking care. And because every safe birth and every child saved is not just a medical success, it is a promise kept to our families and our future.
Medication errors cause more than one death a day, all right, leading to approximately 1.3 million injuries per year in the US, with a total cost, and this is from WHO, $42 billion annually. Pediatric patients are 3 times more likely to experience medication errors more than adults, and we'll look at why. And when we come to our African continent and the low and middle income countries, first of all, we have a challenge. The data is limited. But the data that we have actually shows that we have similar or even higher rates than in our low resource settings than even in the high income countries. And additionally, the burden of harm is twice that of high income countries. When you look at the consequences, prolonged hospital stays, that means a mother will not go to work because they have to stay with the child in hospital. The higher costs. So I have 2 extra days, 3 extra days of dealing with the effect. I have to pay additional costs for the healthcare, disability, or even death, right? So when we come to Kenya, we have higher error rates. So there was a study that was done in one of the level 5 hospitals. I've omitted that. And when they reviewed the medication prescription charts, they found that 75.8% of the inpatient records had more than one medication error. That was around 1,300 and I think 8 prescriptions had errors. Some ranging from dosing errors and others administration errors, right? In another pediatric hospital, they found 74% of handwritten prescriptions contain errors before safety interventions, right? So this, before pharmacy actually intervenes, 74% of the prescriptions had errors. There was another review that was done of neonatal units. As we all know, the most used medication for neonates is Expen-Genta. In my internship, I knew it was Expen-Gentamicin. Yeah? So that's 14% of their orders had errors. Remember, these children cannot talk, right? And still, underreporting is a major concern, as most incidents and near misses likely go undocumented. We don't know about them. And the actual burden of error is actually higher than the reported figures that we have.
So in our practice, we have several safeguards, including mandatory weight documentation at every encounter. We have a pharmacist who double checks the weights, or rather the dosings for especially high-risk medications. Yes, we always have very many phone calls from pharmacy, but we accept them because we understand why these are being given, why we are being conducted. We ensure the care teams understand our care pathways. We provide CMAs, continuing medical education, and then we also try to use standardized syringes for infusions and clear labels for those infusions. Hand hygiene remains the most powerful intervention in newborn care. We focus on the 5 moments of hand hygiene. Infection control will attest to our declining cases of central line associated infections. We are ascribed to bundle care for invasive lines. We also have meticulous equipment cleaning. And as part of routine critical care, we utilize checklists And every morning, we ask ourselves, is this invasive required? Is this line being utilized? Is this urinary catheter necessary? And we go ahead and remove what we do not need. We've talked about safe transitions for our patients. So we standardize our handovers during shifts across shifts and units. We provide the teams with time to have effective communication and handover. Why? Because we understand this is an opportunity for safe care, and this is when sometimes things get left out, and sometimes we have problems for these patients. We use whiteboards in our critical care areas so that families understand what the daily plan is. Families understand what is not to be given to their patients. And even when we have DNRs, advance directives, they're sometimes put on the medical boards so that everybody is clear this patient is not for certain interventions. So basically all we're doing at that time is basically trying to provide safe care for the patient from shift to shift and from unit to unit. Safe care must be equitable. So our systems work for preterms, they work for adolescents, they work for children with complex disabilities, they work for those with chronic conditions, and for those who arrive at 2 a.m. without a referral letter. Equity also means that we have clear pathways for pain management, for nutrition support, for language interpretation, and for safe referral and transport. It also means expanding safety beyond our walls because we partner with referring system facilities, we ensure safe discharge plans, and we also support families to care confidently for their for their children through our home care systems. Safety is also a skill set. So one of the things we do in our department is intensify simulation-based training with our CIMA colleagues, where we focus on neonatal resuscitation, pediatric sepsis bundles, and mass casualty management. At every simulation, we end with a debrief, and we ask what went well, what was hard, what will we do differently tomorrow. We also ensure interprofessional training because teams that train together deliver safe care together.